development, and then looking at the existing models of palliative care in aged facilities and what we call nursing homes in Singapore, and finally, other outstanding issues to consider and how we are planning to move forward. In terms of the local context, Singapore has one of the highest life expectancies in the world at about 85 years, with a health-adjusted life expectancy of 10 years less at 75 years. And what that means is that we are all spending an average of 10 years of life in ill health, something which most people will not want nor look forward to. And the main culprits for this in Singapore are chronic diseases such as high cholesterol, high blood pressure, and diabetes. Diabetes seems to be buckling the trend a little, which hopefully is due to our national war on diabetes, which was declared in 2016 as a nationwide effort to tackle diabetes. Nevertheless, overall chronic disease are still on the rise, and with it, morbidity and mortality. And in Singapore, our population, like Thailand and many other countries, is fast aging, with large cohorts of baby boomers entering post-65 age range. And we are going to be a super aged society in 2 years' time, where more than 21% will be 65 years and older. And by 2050, there will be 2 or less persons aged 15 to 64 for each person aged over 65 years. Similar to the rest of the world, our local studies show escalating healthcare costs till the end of life, where half the costs in the last year of life are incurred in the last 3 months. This is also confirmed by the Lian Center for Palliative Care COMPASS study, which looked at a cohort of 286 advanced cancer patients. So if you follow the dark red line on the curve, which is the full sample of 286 patients, cost of care escalates up till the end of life. And as expected, should you prefer more cost containment, less life extension, as with the green curve, the cost goes down at the end. But what was more interesting was that if you had no preference, which is the blue line, cost remains high. Which begs the question, if we can elucidate preferences earlier and prognosticate better along the disease trajectory, can we help to shift the overall cost curve down? In tackling the issue of our health-adjusted life expectancy, where many of our people will be in ill health for 10 years, the MOH has launched a Healthier SG initiative since last year, where all Singaporeans and permanent residents above the age of 40 will be invited to join this program. And with Healthier SG, the plan is to empower the residents to take charge of their health, register with a family doctor at Healthier SG clinics, which are additionally funded by the government, receive a customized healthcare plan, draw on a wide range of activities provided by community providers to stay healthy, and receive better healthcare information so as to manage their own healthcare needs. And the ministry is doing this not by just implementing Healthier SG through engaging the private GPs directly, but working through the healthcare clusters as regional health managers to link up with GPs so that everyone is linked up within the healthcare ecosystem. So how this looks like in Singapore with 3 public healthcare clusters, also called regional health system. The regional health system teams are in charge of looking after the residents within that geographical area and linking up with the GPs and other community services located in those areas. So in Singapore, the three regional health systems are NUHS, NHG, and SingHealth. So the population numbers that's shown there kind of reflect Singaporean and permanent resident numbers only, hence not adding up to the total Singapore population of about 6 million. And in this new population health model, where the focus is mainly on preventive health, the idea is to hold our residents in the community as long as possible and only flowing them to the hospital and national centers whenever needed. And when they are in the community, linking them up to all the community resources that we have so that they can keep themselves healthy and active. So back to palliative care. So this was a public survey that was done 10 years ago, where 77% of Singaporeans wish to die at home and 70% actually wish for end-of-life care at home. But in reality, only 26% actually managed to pass on at home. And a recent prospective cohort study in end-stage cancer patients revealed a similar preference rate for home deaths, and this was at 64%. But it highlighted the instability of preferred place of death, right? Because at each 6 months time point, more than 25% of the cohort changed their minds about their preferred place of death. So this suggested that their preferences actually need to be re-examined regularly for concordance. So to inch the numbers closer to people's preferences, the Ministry of Health in their work plan seminar in 2022 has set a target to reduce the number of deaths in hospitals from 61% to 51% within the next 5 years. This is also in line with our Healthier SG aspirations of holding care in the community, and is currently one of our healthcare cluster's Healthier SG KPIs. With that, we envision increasing home deaths and deaths in nursing homes. So in the meantime, much has changed since the first National Strategy for Palliative Care in 2011. At that time, there were 10 goals of strategy that were recommended, and it was a report that was detailing the palliative care needs in Singapore. So over the years, MOH has recognized the need for a refreshed National Strategy for Palliative Care, and through the coordinated efforts from MOH and Palliative Care Fraternity, the new National Strategy for Palliative Care was launched in July last year. And in this new National Strategy for Palliative Care, there were 3 main focus areas: access, quality, and palliative care environment. And the components were detailed in the following table, and there were areas of capacity, sustainable care models, affordability, and opioid access that needed improvement. We had to enhance our guidelines and be better at measuring outcomes too. And there is this current movement of national benchmarking. And in terms of palliative care environment, we hope for better holistic support, better community engagement, a stronger leadership, and more research in this field. So for the implementation of the National Strategy for Palliative Care, the Ministry has appointed an implementation committee, which is meeting up monthly together with the Ministry of Health Aging Planning Office, as well as the Agency of Integrated Care. And this is to move the needle on the various work streams that has been identified as part of the upcoming work. One of these work streams is the Integrated Palliative Care Model, which is a push to establishing general palliative care in all settings to be provided as routine care, supported by specialist palliative care providers. So this includes general settings in the community, such as nursing homes, which will allow for better patient-centric care, right siting, and care continuity. So with these recent trends in mind, let us look at our current models of palliative care provision in the nursing home. So in Singapore, there are essentially three main models of palliative care in nursing homes. The first model is the larger scale, which is the healthcare cluster-led services, where hospitals within each healthcare cluster form community teams to engage, upskill, and support the nursing homes. So these teams may be generalist or specialist palliative care teams, or a mixture of both, depending on the model of care put forth by the hospitals. Now, the second model of care is more of the typical specialist home hospice teams we are familiar with, where hospice teams handhold nursing home staff in the work in the nursing home. And in the third model, which is the GP-led model, these will be made up of individual GPs or group practices that go in to support the nursing homes. And I'll be talking a little bit about the mobile inpatient care, MIC at home, which may be also a future model to look forward to. And Project CARE was essentially the first hospital-led nursing home pilot project in Singapore. This care model, which was from Tan Tock Seng Hospital, consisted of a team of doctors, nurses, and social workers supporting the nursing homes 24/7. And it was a successful project showing both good clinical outcomes and economic impact with per resident cost savings in the last 3 months of life. And hence, MOH decided to fund this officially and extend funding to rest of the hospitals. And with this nationwide partnership between hospitals and nursing home, this was a kind of a pilot project that was called the MOH P6A pilot. This started in 2014, and the task was for hospital teams to establish partnerships with nursing homes in close proximity, so as to provide palliative care in situ and avoid unnecessary admissions. So there were a few components to this program: upskilling nursing home staff to do ACP conversations, co-management of patients, training them to do EOL care, and there was joint management as well. And these were the key EOL care elements: so screening and identification of the right patients, ACP and PPC is a preferred place of care discussion. There's care management, capability building, and of course post-death review. So MOH also set cost savings and health outcomes targets for this pilot national funding. And over the years, while project teams did not achieve the cost-saving target, net cost savings were seen in all the teams that embarked on the P6A project. And beyond cost savings, all the teams managed to lower acute utilization, as shown in the bottom table, and to improve concordance with preferred place of death and treatment preferences, as in the top table. As you can see in the bottom table, the acute utilization was broken down to admissions, length of stay, ED visit, and SOC, which refers to our hospital specialist outpatient clinics. So in the next few slides, I'll be showing you examples of how each cluster is managing these hospital-led nursing home partnerships, starting with the NHG GeriCare program. With the GeriCare program, I hope to deep dive a little on program details, while discussion for the other two clusters will be more of an overview. So GeriCare as a program aims to enhance palliative care for nursing home residents, ensure appropriate utilization of acute healthcare resources and right siting, and build capabilities of nursing home in provision of quality geriatric and palliative care. And the mission here is also to leverage on training and technology, as well as creating a community of practice amongst healthcare professionals working in and with nursing homes. So the box over on the left-hand side of this slide with the green titling nursing home refers to activities the GeriCare team does in a nursing home, which I will elaborate in the next slide. Whereas the box on the right with the blue titling Yishun Health refers to the touch points within the healthcare system that the nursing home resident interfaces with. This may be the Khoo Teck Puat Hospital ED, the long-term care service clinics, as well as the long-term care service cohort beds in the community hospitals. With access to this whole health system, care can be escalated easily and admissions averted and care appropriately cited. So patients and residents who are discharged can also be followed up either at the outpatient clinic or directly back in the nursing home. This is the four-pronged approach taken by the GeriCare program, and there is the educate component, preceptorship, intervention, and communication. So in terms of education, there is the capability building through various trainings such as the SBAR course. There's also a palliative care course, an advanced care planning course, telegeriatrics nursing training course, and fundamentals of geriatric care course. And in terms of preceptorship, the GeriCare nurse preceptors will provide clinical support to the nursing home staff, and there'll be regular on-site visits by the GeriCare nurse preceptors. And in terms of intervention, beyond the regular on-site visits, there were regular teleconsultation sessions, whole-staff reviews, multidisciplinary team meetings, ad hoc calls and teleconsults, as well as care integration in terms of intervention at ED, as well as the long-term care service, inpatient ward, and outpatient clinics. So in terms of communication, the GeriCare co-joins the nursing homes to conduct their ACP discussions, family conferences, and also provide grief and bereavement support for the next of kin. In terms of GeriCare education and training framework, the whole idea is a tiered approach to training matched to the palliative care needs. And within the nursing home, the program aims to train some staff to attain intermediate skills and all staff with basic skills. And overall for this program, we can see that in calendar year 2022 and calendar year 2023, compared with non-GeriCare nursing homes, there was significant reduced healthcare utilization, whether this was at the ED or the hospital admission level, or in terms of SOC visits. And again, there were program cost savings, but very importantly, significant clinical outcomes such as symptom control, opioid access, family and staff preparedness, honoring goals of care, and aversion of transfers. And this is just a more detailed slide here comparing the readmission rates between Gericare and non-Gericare nursing homes, showing lower readmission rates with the Gericare program. And in terms of workload, physical visits by both doctors and nurses climbed post-COVID, almost doubling in numbers. And now we move to the NUHS, our Western cluster. And you will see common elements through the programs from the different clusters. And here in NUH Cares, beyond cause and care protocols, there is an additional medical helpline that has been set up recently. So instead of calling the usual emergency helpline 995 for ambulance service and transfer to hospital, the nursing home staff can reach the team for advice prior to the transfer or arrange for direct admissions to the hospitals. So beyond crisis response, specialist support is also on hand to deal with chronic care issues. And this is an example of a screening tool that is used in the NUHS program to identify patients onto the program. And this is a similar multi-pronged approach that's taken. So beyond geriatric and palliative care and ACP causes, what makes the difference is actually the hand-holding and mentorship. So over in SingHealth, the story is also similar. The model in SingHealth is called Eagle Care, and it seeks to train and support nursing homes and improve care outcomes with a shared care model. Over the years, each program has evolved from their own hospitals with a slightly different flavor based on the teams that were leading the program. So you can see in the middle with CGH Eagle Care, and this was led by geriatricians, while the SKH model over on the left was actually led by ED physicians. So they had different training materials and slightly different care models and focus in care. And hence, there was a need to harmonize this as a whole Eagle Care program in terms of not just the care model and service scope, the care pathways, but also the admission to community hospitals. And with time, we plan to onboard more and more nursing homes onto the SingHealth model. So, and this is the ongoing work harmonizing the services while gearing up to meet the MOH population health indicators, of which, if you look at the top bar, reducing average bed days and bill size in the last 6 months of life prior to death is actually a new MOH population health indicator. And with the harmonized model, the three broad aims will be to manage acute illnesses better, kind of provide adequate ongoing geriatric and palliative care support, and to gear admissions more to community hospitals where appropriate, so as to offload bed capacity in acute hospitals. And as with all clusters, there is an ongoing exercise to continually onboard all nursing homes within their region with reporting of onboarding progress to MOH. There is also talk about the need for a stratification as nursing homes themselves come with different degrees of care readiness and needs. There is also this new entity called MIC at Nursing Home, which I will elaborate later. And from NUHS support hotline, there are now talks amongst the three healthcare clusters to set up a national support hotline for nursing homes. The home hospice model, which is the second model I mentioned earlier on, was established much earlier. with our first home hospice service in Singapore established since 1987. And with time, the home hospice teams have been supporting dying nursing home residents in place. Now, with the cluster-led onboarding of all nursing homes, perhaps home hospice teams can now focus on seeing patients with higher palliative care needs and supporting these residents in place without having to transfer them to an inpatient hospice, which is our current practice. And the home hospice team can continue to provide care for more complex patients and maintain their own emergency hotlines. But as you can imagine, there's a real concern for double dipping of resources, especially if case definitions of complexity is not clear or staff are not well trained enough to identify otherwise. In terms of the third model of care that I mentioned, I'd like to talk about St. Joseph's Home. And St. Joseph's Home is one of the nursing homes that has evolved from being GP-led in the earlier days to currently supported by palliative care trained doctors. But beyond that, I actually wanted to highlight St. Joseph's Home to show us that there is much we need to learn from nursing homes as well. And hospital clusters definitely do not have all the answers to good care. For those of you who may not know St. Joseph's Home, this was actually the birthplace of palliative care in Singapore, where way back in 1985, the Sisters of St. Joseph's Home set aside a ward of 16 beds for dying patients. And in the picture at the left bottom is the late Professor Cynthia Goh in her much younger days, seeing a patient with Sister Geraldine at the foot of the bed. And for many years, Sister Geraldine was the executive director at St. Joseph's Home, and under her charge, she led a whole host of amazing nursing home programs, including hydrotherapy for patients, a dusk to dawn overnight respite service for dementia caregivers, and also on-site physiotherapy with her machines. So what was most impressive about St. Joseph's Home was their very successful intergenerational model of care, where a child care center is co-located in the same space with the nursing home, and children and elderly residents interact daily in various manners. Children are also not shielded from death, visiting the hospice and bringing joy to the residents there as well. And when Grandpa dies and the child realizes that Grandpa is not in bed anymore, these occasions serve as lessons that death is not something to be hidden or afraid of, and merely part of life and living. And beyond this intergenerational design, and I love the way, we have all these children's tables together with adult tables in the eating space, there is something that is so difficult to teach that stands out at St. Joseph's Home. If you notice the staff picture on the right upper corner eating out of Corelle plates and bowls, I always remember Sister Geraldine saying that our residents are our guests, and guests must be served with proper cutlery in a proper manner. And in bringing new experiences to our guests in partnership with community is also our duty in enriching their lives, be it inviting Michelin star chefs into the nursing home or using the latest sound beam technologies for the less able to create music and songs in their lives. So amazing programs and the amazing way of putting the resident at the heart of whatever we do, that is something that St. Joseph's has always excelled in. And finally, one last model of care to consider, which is the mobile inpatient care at home, in short MIC at home, also known as hospital at home model. And the idea here is to bring acute level care to nursing homes for a short, defined period of time so as to prevent readmission to the hospital. This is still in an exploratory stage in Singapore and is a very interesting space to watch. So in thinking about the way forward, so MOH, together with the National Strategy for Palliative Care Implementation Committee, has also identified a few potential barriers. And in nursing homes, access to opioids is impeded by lack of manpower to administer opioids, especially at night, and lack of clarity over requirements for storing and administering controlled drugs. There is generally unfamiliarity and low competency when it comes to opioid use, worsened by the rapid turnover of nursing home staff. So the ministry is also currently re-looking at the requirement for 2 registered nurses to administer controlled drugs and putting out new guidance around controlled drug storage and use in nursing homes. There is also an ongoing landscape scan of use of opioids in nursing homes so as to better inform what else we can do to make it easier to access opioids. And some good news on the ACP Advanced Care Planning front, with piece rate funding from Ministry of Health and clusters for each ACP conducted. And hopefully this will also help build the culture of advanced care planning both in the hospitals and in the community, especially in the nursing homes. And as we continue to link all the nursing homes to clusters through onboarding, there is also a need for a national committee to oversee this complex piece of work, looking at tiering systems for support, clinical case definitions for complex versus general care, and we are also revising our national guidelines for palliative care to include guidance for general palliative care. And as services expand, it is also important to look at the roles and responsibilities so that the EOL care provision is clear. And as a fraternity, we have promised expansion of home care capacity by end 2025, which is next year. And this means a new influx of manpower, providing more opportunity for us to rethink and reshape our services so as to better meet the needs of our people. This is actually my last slide, and I would like to end by thanking various people who have helped me with this presentation with their generous sharing, and I really wish all of you a very fruitful conference ahead. And as I will not be able to join you in the panel discussion, please feel free to email me your questions and reflections, and I would love to hear from you. Thank you very much for listening.